Like to invite my co-moderator, Professor Michael Dunn, up to help co-moderate. And we have on the panel Dr. Lionel Cheng, Mr. Teng Chok Ming, and I think Professor Chester Simon, and Professor Cameron Stewart Chesterman, and yep. And I think our speakers are here as well. So did I miss anyone? I'm sure I missed someone. Did I miss anyone? Okay, no. Michael, do you want to maybe start the introductions?
Sure. Let me start with this end of the esteemed panel we have lined up here. Our first panelist on the right, Professor Simon Chesterman. Simon is the David Marshall Professor and Vice Provost of Educational Innovation at NUS, and also the founding Dean of NUS College. He's, importantly for today's purposes, also the Senior Director of AI Governance at AI Singapore, as well as a major contributor through 20 academic books and, impressively, 5 novels, I understand, as well. Great. And to his right, we have Professor Cameron Stewart. Cameron's Professor of Health Law and Ethics at the Sydney Law School and an associate member of the University of Sydney Medical School, trained in economics, law and jurisprudence, and previously worked at the Supreme Court of New South Wales and also in private practice. Also a fellow of the Australian Academy of Law. Welcome, Cameron.
And on my left is Mr. Teng Chok Ming, the lead author on the SingHealth policy on AI governance. He has an illustrious career in various audit and governance platforms, including the Ministry of Health. And next to him is Dr. Lionel Cheng, good friend from a long time back, a radiologist, but in this context, he's the Chief Data and Digital Officer for Singapore General Hospital, as well as the Clinical Director for AI, Future Health Systems Department at the Singapore General Hospital. So with that background, maybe we can launch the discussion. I think we have a lot of interested parties in the audience, Ben, Marcus, Joseph, everyone is here. So let's get the ball rolling. Any questions, comments from anyone? And whether from the Mentimeter, if there's any thing. So maybe I'll Lionel, do you want to start? Oh, great, there's a question from the floor.
Is this on? I was just going to ask about, we were talking about governance and oversight, and I know there wasn't a lot of all the details, but I was wondering about the extent to which public and patient involvement is currently being practiced in these various entities, patient representatives in those groups, because as we saw, a lot of these issues relate to patient trust, public trust in AI. So to what extent can and do we have patient representatives or other such relevant groups involved in AI governance and oversight? Over.
Really good question, a nasty one at that too. So we'll have, who wants to give a go at it? What is the patient's voice? Yeah, so that really is the question. I think, Simon, the mic has landed on you.
Well, so maybe I'll deflect the question and answer a slightly different one, which is why we're having this conversation now. And I had a brief chat with Cho Chuan before he had to go. And one of the things he highlighted is actually there's a robust history of law always struggling to catch up with technology. And some of you might be familiar with the Collingridge dilemma. This is the idea, back to David Collingridge, wrote in 1980, at an early stage of technological innovation, it's easy to regulate, but you don't know what to regulate. You don't know what the problems are. The longer you wait, the clearer the problems you're trying to avoid become, but the cost of regulation goes way up. And so the link with the question is, okay, who is making these decisions? Because often there is a number of huge misapprehensions around AI, and I'll just focus on 2 of them. One is that artificial intelligence is artificial and intelligent, and often it's neither. And a lot of what we've been discussing is actually natural processes, because it's human decision-making that's being replicated by these machines, and the machines are merely reflecting our biases. Every time we talk about algorithmic bias, what we really mean is it's revealed there are biases in the data set for some of the reasons that have been discussed. The second problem is, and this is the direct link with the question, the solution from the lawyer is to say consent, patient autonomy. And the dirty secret, as we've been alluding to, is the more complicated medical procedures become, the harder it is for a patient or indeed a doctor to understand. And we have a rich history of this in technology. And I can summarize this little bit of audience participation. The foundation of most personal data protection legislation these days is consent. Put your hand up if you have clicked I accept to terms and conditions in the last year. Go on, be honest. Keep your hand up if you read those terms and conditions. I publish books on data protection. I don't read them. It's pointless. And so the problem is we have this illusion that we can bring this all down to individual decision-making. And the reality, the history of medicine is the doctor-patient relationship. And the complexity of technology, the sophistication of these devices is going to make that harder and harder. So a long way of saying, I don't know the answer to your question, but it's an important one to ask.
Can I follow up with that and just make the observation that I don't think anything that's been said today hasn't already been discussed as a problem in some other dimension of healthcare. So there's nothing special about AI. So I'm going to put that out there. Bias in evidence, our understanding of truth, what is disease, what's effective, who gets to make decisions, how do you inform patients, how do you respect autonomy? Okay, that's not new. We've got the tools to talk about these things already. So from a regulation perspective, and for me, regulation is not just what the law says, but what the professions say, how we discuss things in terms of how we regulate ourselves as professions. So much broader concept than just law. But we've already got tools for dealing with all of those things. So to a degree, I think we need to be wary of exceptionalism. This is the problem. Whenever a new technology comes in, we go, oh, we got to regulate it. And coming back to your point, when the new technology emerges, it's easy to regulate. Australia, for example, regulated human cloning when a lamb was able to be reproduced. I don't know why it did that. We still haven't got a cloned human as far as I'm aware. I know there's that Italian guy and he says he's done it. But we passed legislation that is absolute garbage because it's to deal with a problem that didn't exist in a way that we didn't understand. Of course, it's going to be garbage. And I think we've got to be careful that we don't pass laws with AI that do exactly the same thing because we're worried about, we've got this fear of Spectre or Terminator films or whatever it is that's motivating us in a regulatory sense. The regulation is there already. Common law is there already. Protection of privacy is there already. Therapeutic goods law is there already. Those things are there. We're not coming in a vacuum. All right, the norms are there. We just need to perhaps modify them a little bit or monitor and watch about how we can make those regulatory forms a bit more effective for artificial intelligence. And I'll come back to what you said there, Simon, about informed consent. Informed consent doesn't exist. It's not informed consent. It's a duty to provide information to patients about what risks are material to them. So when we set it up like that, most of the time, it's deliberately ignorant consent because the patient doesn't want to know. And you've satisfied your duty, right? I have provided the information to the patient that the patient wanted to know. And a lot of the times, the information is being provided to the patient where the GP doesn't really understand it. And Joseph's example of aspirin is a classic. We know that this works, but we don't really know how it works. Why doesn't that work for informed consent in AI? We know that this works, but we don't really know how it works. Okay, most patients will go, is it going to work? I think it will. Okay, let's do it. They're not going to care about the fact that it came spat out of some machine. They don't care. They don't know about randomized controlled trials. They don't know whether it's phase 4 evidence. They don't know any of that stuff. So let's not overthink it. Let's not overdo it and jump to a regulatory response, which is reactionary, not well thought out, done in a space of ignorance. We're gonna do ourselves a lot of damage if we do that.
Cameron, can I quickly come in on it? So pushing your exceptionalism argument even further, is this an argument against novel modes of governance in health institutions? Because of course we have established clinical governance frameworks, we have established medical device review bodies, we have a whole range of institutional frameworks in place, research ethics committees, etc. Is this an argument that also extends to resisting new modes of governance in these institutions as well, do you think?
I think it's for making them adaptive, and I'm going regulatory theory a bit here, but it's making them forms that aren't rock solid concretized forms of legislation, but instead doing what what Joseph talked about. That I thought that was brilliant. Like the idea that, okay, we're going to get a gang of experts together that are dealing with this problem. They're going to state what their problems and concerns are, set down a set of principles that are going to be monitored and watched, and then we're going to see how it plays out. That's exactly what we need to do, because that's not setting us in concrete. That's allowing us to reflect and adapt. And then the responses will be more measured and they'll be more careful. Will there be mistakes? Of course there'll be mistakes, but the concrete legislation is going to make mistakes. The only thing that's going to stop it from hurting someone is to ban it. Okay, maybe we do that later. I don't know. We're banning TikTok all over the place, so maybe we'll do that with AI. But that's probably I would just ban TikTok because it's annoying. But that's a whole other box and dice. So that's the form of governance I think that would be that's adaptive or responsive or whatever you want to call it.
Could I add a comment to that? Maybe before Chok Meng speaks, since Chok Meng comes up with the policy, I'm sort of sandwiched in between at the institutional level where I sort of understand and give inputs on the policy, then we have to implement it and come up with the governance and make it work. So maybe I want to talk about patient autonomy, right? I think there was a very nice issue and the framework saying that patients should be aware when AI is used in their diagnosis or treatment. So come to the operationalization of that framework and the governance policy, I think we face the problem where AI is unequally applied across multiple different specialties, right? So I think if we think in terms of a clinical decision support algorithm, diagnosis A or risk score or something like that, it's quite easy to compartmentalize that in the doctor-patient relationship. So it says, oh, we're using this algorithm that's going to predict your risk of disease ABC, and this is how it works. So we're going to tell you we're using that. Do you consent? Do you agree? But the reality is that AI is applied in so many domains in medicine, right? So I'm a radiologist, right? AI is used in image generation, right? So we put a patient in a CT scanner. AI is used to reconstruct the image, to give the image that we see, right? So now do we explain that to the patient and says, hey, this particular brand of scanner has AI embedded inside the algorithm that churns out the image of your brain or the liver? So at the end of it, it's going to become so pervasive, right? Your queue management and the priority in which room that you saw the doctor could also have been impacted by an AI algorithm. So what will happen is on the ground, we'll put up a blanket statement that says, AI may or may not be used in multiple instances in this hospital experience. Do you consent or not? And again, becomes useless information for the patient. It's not actionable. It doesn't empower them. It is more of an institution protecting itself. Maybe a quick point about equity as well. Right? I think, of course, we all fully endorse and agree with those principles. But at the same time, when we pass those governance requirements, we have to think about how we empower the ground to test and implement this. Right? If we say we have to regularly test our algorithms, see whether it's generalizable from a different population to ours, do our people even have the ability to get those data sets out to do those tests? And if we have a regulatory or governance framework that requires that, we may put a very onerous requirement on the ground that they may not be able to fulfill. So especially in certain circumstances where they're not as advanced. So just some thoughts out there.
Yeah, just to add on to the point, probably sharing my experience from Singapore context, how this policy come about. Just now the audience asked, where is the patient voice? So in Singapore, I think we cannot collectively get all the consensus from the patient to voice collectively as a voice. So it's more like a Singapore way of doing things. Is more we get really to anticipate things going to happen. So for this case, because the use of AI is getting prevalent, so it started actually my boss, the GCDSO, just now we mentioned, talking to a very advanced AI specialist, Dr. Daniel Ting. So they started moving the idea that there is a need to have this piece of work, but it's just an idea. So that quickly activated a group of interested stakeholders, including our data analytics team, our AI office, and also various clinicians, including Dr. Naina. So we actually formed a work group and then discuss on the needs, and that catch the attention of the top management. The GCMB, the DCOs are all looking through the paper and give very strong, robust inputs, because they see that without that fundamental framework, it will be a lot of downstream impacts. So I guess I can say that is a Singapore way of doing to get the collective wisdom from our own governance bodies. So in that sense, in SingHealth, we have governance body to do this part of work. Yeah, I hope probably it's the same as some other countries as well.
Just to add, maybe I'm not sure at 5:30 whether the organizers want a provocative statement, but a famous person, Steve Jobs, I think he's called, used to say that the customer doesn't know what he wants. So here we are already struggling to understand AI. I know there are really lots of smart people out there, but I don't think it's easy to say that they know how AI works in healthcare. So it might be really tricky to have the patient. I mean, information on health is readily available if you Google it. But when patients come and tell me they want a CT scan because their friend died last week, it's very hard for me to explain why a CT scan may not help them live longer. So it's a complex issue. Marcus, yes.
Maybe I can just respond a little bit to some of the points brought up. So I like the point that Ben Goldstein made, earlier on, that the opportunity that we have is actually to bring in an alliance of the clinicians, the administrator, the policymaker, but also of the researchers and the patients. So how do we bring in the patient's voice? I think that is one opportunity where good qualitative kind of research, and engagement through, a thoughtful kind of evaluation of technology will be very, very helpful for us moving forward. And this requires that, the health system would partner with the academic institution, the medical school, the researchers, and, people like ethicists, people who are thinking through the governance and the medical legal. And, that I think that the opportunity is that there should be freedom in that space to actually explore these ideas without constricting, initiative from the ground, and stifling all innovation and stifling all progress. Because we need to recognize that there is an alternative risk, which is do nothing, right? And as I tried to allude to in my talk earlier in the day, doing nothing is not an option, because we are sort of like hurtling towards this silver tsunami, and there are pressures on the ground, and there are urgent needs that need to be met, which has to be met with technology, innovation, better process, better applications, etc. Right? So I think that doing nothing is not necessarily the safest or the lowest risk option that we have. The question is then, how do we move forward and do something, but do something thoughtfully, based on data, based on evidence, based on best process, best standards, and then translate that onto the ground to benefit patients. So, and this is where, implementation science comes in, technology assessment comes in, and this is where it's crucial to partner, between the health system, the researchers, and the patients.
Brilliant.
Can I just pose a problem? So I agree with you and Ben Goldstein that there may be huge advantages. And one of the advantages of AI is you have to get your values clear, either in your programming or in your evaluation. And so you mentioned very correctly a whole range of factors that might go into evaluating futility. And one of them is questions about distributive justice, around how we balance all of the community's health needs. But people and governments and the law has robustly been resistant to discussing how we trade different lives. And AI in many ways will force us to do that. And you have a transplant committee here in Singapore, I think, which doesn't even make transparent what its rules and principles are of allocating organs. So do you think there is the prospect of actually involving the public and patients in a discussion about making values explicit? Or will the government make this decision? I find it hard to see how we can involve people in a meaningful way to make these very difficult decisions. So, I mean, how are we going to go to that?
Simon?
So it's a great question. It's one of the key questions in this space. And again, as a non-medical practitioner, there are lots of other examples of this. I mentioned data protection. The great myth of data protection is that consent. None of you read your terms and conditions, but also there's a huge disjunction between what people say and what they do. And the same is true in the AI space. So Joseph has just had to go, mention the autonomous vehicles, and I'm pleased we've made it 3 hours without a trolley problem. And I don't propose to go into that, except to say that there was a study about the limit case of an autonomous vehicle, and it's going to crash into school children. Should it sacrifice the driver to save the school children? Yes, a majority of people say yes. Would you ever get into a car programmed that way? No. And so there's this disjunction. I suspect implicit in your question, in your observation, is that people in the abstract would say, yes, we should allocate medical resources equally. What if it's you? No, you should allocate.
I suspect some of these questions, as Julian and Simon, you guys alluded to, is best left not answered. And sometimes in life it's like that, we don't have to answer everything because that scenario might never occur, and bringing it up may open a can of worms. So I think this is robust. I'm glad we are not all agreeing with each other. So it's always nice when we don't all agree with each other. But I think that's the point of this symposium. It shows us that there's a lot that we still have to unpack, and I think we need to have another one next year. Michael.
Yeah, I wanted to just ask, if I may, a question on harmonization, because this seems to me to be a particular challenge in the AI governance in health space at the moment. There's a proliferation of frameworks, proliferation of principled guidance, and even potentially in Singapore, a range of different institutional governance responses. Is there a danger here that we just build a system of governance that can't speak to each other, particularly when we think about the fact that I presume the health systems need to be able to converse, clinicians need to be able to talk to each other and collaborate, and patients need to know that they're going to get a fair and equal access potentially to various interventions. Is there a danger here of proliferation of governance frameworks and a sort of abandonment of the principle of harmonization? I wonder if the panel members have any thoughts on that.
Yeah. I'm Australian, so we always have proliferation of laws because we've got only like 24 million people in 8 different jurisdictions. But so I don't have a problem with that at this stage. I think what will happen is what happens with every new technology is that you'll eventually get a profession emerge that speaks with authority over it. And it may not be the medical profession. I think my own gut feeling is that there'll be a new kind of health informatics profession that will emerge out of this, and that they will speak with authority on it. But again, every time there's a new health technique or health technology that happens, and sometimes it's a medical specialty, sometimes it's not, it's passed off into some other whole new profession. So at the moment, I think we're seeing this proliferation, which is great. That will cause some confusion, but eventually there'll be coalescence of those normative frameworks. And I think eventually we'll see some form of international consensus, and that's building already with WHO and other things. So I think it's a good thing.
Maybe even through today, I guess.
Just to add on that, for Singapore, another advantage is we have a very centralized MOH. They're always there. So when we initially started with all this policy, as you mentioned, it's actually by individuals. But MOH is also taking a more holistic approach. They wanted to collectively develop one AI governance as well as ethic policy, which is in the work. So I believe moving forward, it will be consolidated into one. Another point just to mention about what you have asked as well, about whether certain of these tricky questions, I quite like Marcus' answer, because before all these things set up, we have nothing. So we need to have some baseline to bring people together to say, let's discuss all these things openly, even including basic things like tracking of AI programs. We didn't have anything. So I kind of like a lot of clinicians told me about when I developed this policy with the team. They keep saying that this is a AI document, and not AI, sorry, agile document. That means you need to keep evolving. So I will be very much thinking that as we move along, once we settle the baseline, then we would have some other consideration, including some of the very interesting topics, such as who to decide the algorithm is good. There may be some needs to have the expert panels to be set up and as a reference to give an objective opinion. Thanks.
So I think we're out of time, is that right? Yeah. So I'd like to thank the whole panel for their contributions. Thank you very much. Great way to conclude the conference. I think we have one final session just to say farewell to everybody. So please bear with us. Thank you.
Thank you everyone for the discussion on AI governance. And to quickly conclude the seminar, I'd like to invite Professor Marcus Ong and Dr. Victor Koh to give a closing address. Prof. Ong and Dr. Koh, please. One of you can come up first. Okay, Dr. Koh, please.
Thank you, sir. So kind of you to defer to me, Marcus. It's my pleasure to bring this very productive and stimulating session to a close. This is the beginning of a week of deliberations for a working group that we, with the Centre of Biomedical Ethics within the SHAPES program, which I direct, the Science, Health and Policy Relevant Ethics in Singapore project, which is funded by an NMRC grant, will be running throughout the rest of the week. So you've really seeded the ground very nicely for us in our future deliberations, even if you pointed perhaps to some of the futility of the task of trying to arrive at anything like a consensus, which I know we won't in the course of the week. Essentially, I'd just like to thank my co-organisers, particularly Professor Marcus Ong and his academic team with Duke NUS, Sing Health, and the team of administrators led very ably by Wei Chung and Eileen for all the work they've put into this event. Thank you for inviting us to your party, because you really initiated this event and we entered the fray somewhat later in the day and added some further resource to it. So thank you very much indeed for that. Thank you, of course, to our guest of honor, Professor Tan Chua Chuan, who gave a very stimulating and actually quite rich and detailed opening address, even though he was quite self-effacing and said it was broad strokes. It was actually quite detailed. Thank you also to our VIP guests, Professor Simon Chesterman, Dean of NUS College, and Professor Chong Yap Singh, Dean of the Yong Yew Lin School of Medicine at NUS, and Professor Joseph Singh from the Lee Kong Chian School of Medicine, NTU. Thank you, gentlemen, for your participation. And we've had the bringing together of some mighty minds this afternoon in these very weighty deliberations, even if the conclusions are ultimately still very open-ended. Thank you very much, everybody.
And just my word of thanks, just to echo Victor's comments. We really want to acknowledge the staff from the Center for Biomedical Ethics at NUS, for their support and active collaboration, and also my staff from the Health Services and Systems Research at Duke NUS, as well as the Health Services Research Center at Sing Health. And can I invite all of us one last round of applause for all our speakers and panelists today? And thank you very much.